And here you can see how sinuses are so strategically located in close proximity to the orbit and the skull base. You know, the margin of safety in sinus disease is so less. You have to be very accurate. Even you have to respect the sub-millimetric distances so that you don't get disoriented and give complications. And in order to do that, you need to have a good three-dimensional dynamic imaging, because certain structures are best seen in certain cuts. Axial, coronal, sagittal together give complete information. And to this, the dynamic information helps you relating each other in all planes. It's not about getting CT scan done simply. It's about fine sections, multiplanar CT scan done, and then you can run on your software to see dynamically everything. So this particular patient, we have discussed in the morning about understanding this disease at the molecular level till the concept and decision making, and then various endotypes. So this first case starts with an interesting endotype. This is a case of allergic fungal rhinosinusitis. And what you saw, what we discussed that in the afternoon, allergic fungal sinusitis present distinctly with certain classical features on radiology as well. Can you see something?
Yes, sir.
Heterogeneous hyperdensities, wide ballooning of the sinuses. Disease is trying to push the sinuses out towards the perisinus area, and this is how this kind of the disease presents. See this fungal eosinophilic material which is presenting as hyper and hypodensities. I hope I am audible.
Yes, sir. Audible, sir.
So this patient as a classical, see, this has all the classical signs and symptoms of allergic fungal sinusitis. This is an endotype. If you remember, we discussed with a classical presentation. These patients are allergic to fungus. This patient has a high IgE as well. Classical unilateral disease, classical heterogeneous hyperdensities, and the treatment. Now coming to the treatment, it involves, see this, full house sinus surgery on this side. Full house sinus surgery on this side, removing all this antigen and eosinophilic material, and to give wide openings for the future surveillance and future topical steroid irrigations. That is the goal of the surgery. So we have to address all these sinuses unilaterally. We will respect not to go to the opposite side as we discussed, to give disease to the opposite side. So CT scan has a role in confirming your diagnosis. Now anatomical details. What we expect from the CT scan is to give us three-dimensional information about the anatomy of the patient dynamically. See this, in a dynamic manner, I have reconstructed to all planes. If I take my cursor here, you can see the frontal sinus in all planes, and this is the sail behind the frontal sinus. See, in anteriorly, this is the frontal sinus. Behind the frontal sinus come, if I go, see this is most anterior. Looks like multiple septations, but as you go behind, see this, these were incomplete septations giving the picture of scallopings. And now this is true intersinus septum, and these are the two frontal sinuses, pneumatizations in the frontal bone. And what we see here, the left is opacified and right side is absolutely clear. Now, as we, from here, as we go behind, until now, this is the beak. See, this is frontal sinus anteriorly. This is, the floor is formed by the beak. Now, when we are coming from anterior to posterior, where the beak ends is the beginning of the frontal sinus drainage. So now we are going behind. See, the beak is intact. As long as beak is intact, is the sinus proper, and now is the beginning of the frontal drainage pathway. See how the frontal sinus is draining over here. this classical unilateral, you know, opacity. Now, see now, my frontal sinus was until here. See the beak, see the beak.
Yes.
Now,
Yes, sir.
as I go behind, now the frontal sinus ends. Okay.
Yes, sir.
Now, this pneumatization going above the orbit, bilaterally going above the orbit, behind the frontal sinus. Now the frontal sinus is ended. Behind the frontal sinus, this is supraorbital pneumatization. See this? This disease
Yes.
is massively involving the supraorbital cell. And this cell is extending above the orbit. This cell is behind the frontal sinus, just caudal to the frontal sinus and going above the orbit. Now, as we go behind, see now, this is the cribriform plate coming into picture. See the cribriform plate, crista galli, the olfactory fossa. This is supraorbital pneumatization. See this huge pneumatization of the supraorbital system, both sides supraorbital cells. Now see inside the orbit. Wanted to show something inside the orbit with changing the intensity, window setting. This is optic nerve. This is medial rector. This is superior oblique. Now as I go behind, see at the confluence of medial rectus and superior oblique, see here, this is beaking of the orbit. Beaking of the orbit. Beaking of the orbit. Can you see some structure going out?
Yes, sir.
That's the bony canal. That's the bony canal for the anterethmoidal artery.
Anterethmoidal artery, sir.
See how posterior it is. We started seeing the sagittal section. We started here. Here the beak ends. And from the beak, if I refer to this canal here, see from the beak, it is more than a centimeter behind. So you don't need to frighten yourself. See, more than a centimeter behind. Can you see?
Yes, sir.
When you work with a 70-degree in the frontal sinus, don't worry about the anterethmoidal artery damage. It is far behind. See, I'm coming back anteriorly. I'm coming back anteriorly. That's the frontal sinus. Now I'm going behind frontal recess start, supraorbital cell start, going behind, and now the anterethmoidal artery starts. See here how posteriorly it is, and where the anterethmoidal artery is, this is the beaking of the orbit where the artery is living in a bony canal from here to the, see, this is olfactory fossa of the brain. This is the lamina, cribriform lamina, this is medial lamella, this is lateral lamella. Medial lamella, lateral lamella continues with a thick frontal bone. This ethmoidal lateral lamella continues with a thick frontal bone, and this artery perforates the lateral lamella to enter the cribriform plate, the olfactory fossa. Now, from this point, if I go behind, the anterethmoid ends. See now the cribriform ends,
Yes,
and
sir.
the postethmoidal roof starts. That means anterior ethmoidal artery traverses through the posterior most part of the anterethmoidal roof. Got my point?
Yes, sir.
Where the artery is, behind that postethmoidal roof starts. See this ballooning of the allergic fungal mucin, pushing the septum to the opposite side. This is all ballooning. It is not perforating. And now as you go behind, see the entire postethmoid is covered. All, see the big cells in the postethmoid, no septation seal, all material, hyperdense material. Now the sphenoid comes. This is the orbital apex on both sides. The sphenoid comes, same hyperdensity continues in the posterior part of the sphenoid, and here behind. These are two sphenoid sinuses. The right one is bigger one. The left is the smaller one. And as you go behind, you see this thick bone separating the optic nerve from the sphenoid sinus. There is no, dehiscence of the optic nerve or carotid artery or anything in the sphenoid sinus. So this is a classical picture of one of the endotype, that is allergic fungal rhinosinusitis in this patient.